Hi, welcome to my today's classroom. In my today's classroom, I will be discussing about chronic pancreatitis, clinical management of chronic pancreatitis, how to approach in a case of chronic pancreatitis. This chronic pancreatitis is very common in cases of acute pancreatitis which is associated with alcohol. Whenever there are repeated episodes of acute pancreatitis, it may lead to chronic pancreatitis. Apart from alcohol, there are many other conditions which can lead to chronic type of pancreatitis. In order to properly classify the causes of chronic pancreatitis, a classification system has been made, and this classification system is known as TIGAR-O system, in which number one T is representing toxic and metabolic conditions which are producing chronic type of pancreatitis. In toxic and metabolic conditions which are producing chronic pancreatitis, alcohol is on number one. So whenever a patient is presenting with chronic type of pancreatitis, and if there is history of alcoholism, always convince the patient, always tell the patient to stop alcohol immediately. You tell the patient that even a drop of alcohol is poisonous for her, will increase mortality of the patient. So the first most common toxic factor which is causing chronic type of pancreatitis is alcohol. Second one is smoking. Smoking also induces pancreatitis. In recent studies, it has been seen that if an alcoholic who has developed chronic type of pancreatitis, and if he is smoking, then chances of further progression of chronic pancreatitis is more. So these are the toxic factors. Apart from this, other toxic factors are hypertriglyceridemia, hypercalcemia, and hypercholesterolemia. So these conditions should be properly controlled in a case of chronic pancreatitis. So one must search for the evidence of hypertriglyceridemia and hypercholesterolemia in these patients by various investigations. The second letter alphabet which comes in the TIGAR system is I. I is suggestive of idiopathic chronic pancreatitis. Now this is an exclusion diagnosis. If you have investigated thoroughly, you have done the clinical examination thoroughly, and still if you cannot find the cause of chronic pancreatitis, then you will label it as a case of idiopathic pancreatitis. The next alphabet in this system is G, that is genetic. Sometimes chronic pancreatitis is genetically based. You may get family history of chronic pancreatitis in these patients. So one must search with the help of historical evidence the genetic chronic pancreatitis. If there is any family history, then you can keep possibility of genetic chronic pancreatitis. Then the next alphabet is A, and this A is suggestive of autoimmune type of chronic pancreatitis. Now this autoimmune type of chronic pancreatitis is usually associated with other autoimmune disorders. So in these patients, you will have to inquire about autoimmune disorders like systemic sclerosis. You will have to inquire about rheumatoid arthritis. You will have to inquire about Hashimoto's thyroiditis. You will have to inquire about Sjogren's syndrome. These are all connective tissue disorders which can be associated with this chronic type of pancreatitis. So one must rule out the different autoimmune disorders if they are usually this type of chronic pancreatitis is associated with other autoimmune disorders. So if you are getting history of autoimmune disorders in the family, and even if those autoimmune disorders are not present in the patient and there is only chronic pancreatitis, then it may suggest that probably the connective tissue disorders are producing this type of chronic pancreatitis. The next alphabet is R in the TIGAR system is R. This stands for recurrent pancreatitis. Now this recurrent type of pancreatitis is seen usually in alcoholics, and even in patients who are having a tumor of bile duct or tumor of ampulla of Vater, or any dysfunction of sphincter of Udy, or if there is any stricture in the bile duct or in the pancreatic duct, then in these cases there are repeated chances of pancreatitis, acute pancreatitis, and this will lead to chronic type of pancreatitis. Then comes O, that is obstructive. Whenever there is any obstruction in the drainage of pancreas, then in those conditions, patient may develop chronic type of pancreatitis. Again, in this obstructive variety, you can keep stricture as one cause, you can keep sphincter of Oddi dysfunction, you can keep any tumor which is obstructing the pathway of bile duct and pancreatic duct. So this is the classification of various causes of chronic pancreatitis. So if the patient comes with chronic pancreatitis, and if the history is suggestive of chronic pancreatitis, one should rule out one by one from history all these different causes. Now, these patients of chronic pancreatitis, how they present? First of all, you will have to decide whether it is chronic pancreatitis or something else. So in these patients, in past, you will get history of acute pancreatitis, maybe because of alcohol or any other cause. It may be recurrent type of pancreatitis. So these patients of chronic pancreatitis, they will present with abdominal pain, but every patient will not present with abdominal pain. That means it doesn't mean that abdominal pain is diagnostic. Now, whenever these patients they present with abdominal pain, there are two types of abdominal pain. One is known as type A abdominal pain, in which abdominal pain is dull aching type and it is episodic. Sometimes pain is not in abdomen but is in the back, or sometimes it may radiate from epigastrium and umbilical region to back. So this is episodic type A abdominal pain. Now when this pain persists continuously, that is known as type B abdominal pain. So in cases of chronic type of pancreatitis, patient may present with two types of abdominal pain: type A pain, which may be intermittent, it may be episodic, and if it is continuous, that is known as type B pain. So though abdominal pain may be present in chronic pancreatitis, but it is not diagnostic. Many a times patient may not present with abdominal pain. Now, patients of this chronic pancreatitis, they will present with features of pancreatic insufficiency. So on clinical examination and in history, you will have to look for the features of pancreatic insufficiency. In pancreatic insufficiency, the first clinical feature which appears is malabsorption type of symptoms. In the malabsorption types of symptoms, you will get history of steatorrhea, you will get history of oily stools. There is oil in the stool, there is fat in the stool, there is steatorrhea, there is protein malabsorption. As a result of protein malabsorption, patient will become lean and thin gradually. There is wasting of muscles in these patients. So there are features of malabsorption: excessive gas formation on taking fatty meals. Sometimes after taking protein meals, there is diarrhea. So these are the features of malabsorption symptoms. So in these cases, you will get features of malabsorption symptoms. Another thing is you will get features of diabetes. Patient will present with polyuria, patient will present with polydipsia, patient may present with polyphagia. So there are classical features of diabetes mellitus, and these features will simulate type 1 diabetes mellitus, that is which is seen in type 1 diabetes mellitus. So these patients, they become lean and thin, just like patients of type 1 diabetes mellitus where insulin is required. So patient will present with diabetes. So diabetes and malabsorption type of features are the two most common features in these patients. Because of malabsorption, many a times these patients may develop calcium deficiency, and because of calcium deficiency, in long term, patient may develop pathological fractures. So always monitor calcium deficiency in these cases, monitor fat deficiency in these cases, and control diabetes in these cases. So these are the two main important symptoms, main historical evidences in the chronic pancreatitis. First is abdominal pain, which may be present or may not be present, and number two is malabsorption syndrome and features of diabetes mellitus. Sometimes malabsorption syndrome features may simulate that of diarrheal variety of irritable bowel syndrome. So usually these patients of chronic pancreatitis will present in this way. Now, how to proceed further? Now, if you are suspecting the chronic pancreatitis, always first go for the laboratory investigations. In the laboratory investigation, fecal pancreatic elastase 1, this serum level of this enzyme is measured in the stool in 24-hour collection of the stool. If the content is less than 100 micrograms per gram of stool, then you can say that there is chronic pancreatitis. So this is the specific test, this is the diagnostic test, but many a times this diagnostic test is even positive in irritable bowel syndrome diarrheal variety. So the clinical examination and other investigations have to be done in order to make the diagnosis. Apart from this lab investigation, you can go for CT scan of abdomen. In CT scan of abdomen, you can assess the surrounding areas of pancreas. You can assess the parenchyma of pancreas. What is the condition of parenchyma of the pancreas in the surrounding area? Sometimes you may get pseudocyst, you may get fluid collection, you may get multiple abscess formation in the CT scan. So CT scan is done to rule out all these complications in chronic pancreatitis. The second investigation which is to be done in this chronic pancreatitis is MRCP, that is MRI. In this MRI, the whole of the tract, that is pancreatic and bile duct, both of the tracts are seen, and in these tracts you will have to rule out any stricture, any fibrosis. You will have to rule out any calculus formation inside the duct. This MRCP is very sensitive in detecting the strictures and the calculus, and even if there is inflammation in the duct. If there is any sphincter of OD dysfunction, that can be detected in MRCP, because in this sphincter of OD dysfunction you will get stasis of pancreatic enzymes and pancreatic secretions and stasis of bile secretions. So MRCP and CT scan is must in the diagnosis of chronic pancreatitis. Apart from this, nowadays endoscopic USG of pancreas is done. From at the level of duodenum, endoscope is introduced, and from the duodenum whole of the pancreas is imaged. And this test, endoscopic ultrasonography, is a highly sensitive test. In this test you can detect calcification inside the pancreas, you can detect any obstruction in the pancreatic duct, and you can also have the view of pancreatic parenchyma and the surrounding structures. So this is very useful in these cases. In case of chronic pancreatitis, apart from this endoscopic ultrasonography, you can do ERCP, and with the help of ERCP again you can make the diagnosis at the cause of chronic pancreatitis and the structures which are damaged by the chronic inflammation can be visualized with the help of ERCP, endoscopic retrograde cholangiopancreatography. You can detect stricture, you can detect tumor, you can detect any stone in the bile duct. With the help of ERCP, you can give shockwave lithotripsy if there are pancreatic stones, pancreatic duct stones. You can put a stent inside the duct if there is any stricture there. So this ERCP is diagnostic as well as therapeutic. The next investigation which is to be done in chronic pancreatitis is gene study. In the genes testing, this is usually done if you are suspecting genetic factor as the cause of chronic pancreatitis. You are getting history of chronic pancreatitis in the family, then in those cases you will do gene testing. The next is testing of function of pancreas. In this testing of function of pancreas, injectable secretin is given, and then the pancreatic secretions are collected in the duodenum by a drilling tube, and this pancreatic secretion is then assessed for enzymes and other contents, and we can analyze it and show that there is deficiency, exocrine deficiency of the pancreatic secretions. Recently, nowadays, a mixed triglyceride breath test is done. With the help of this mixed triglyceride breath test, again we can make the diagnosis of chronic pancreatitis. So this is how these investigations are done in the cases of chronic pancreatitis. Now, once you have made diagnosis as chronic pancreatitis, how to manage these cases? First thing in management is, first of all, you will suggest patient to stop smoking. You will suggest patient to stop alcohol. So these two conditions, if you are suspecting that it is because of alcohol, though if it is not because of alcohol, then also you will ask patient not to take alcohol, not to do smoking. This should be done. If patient is suffering from hypercholesterolemia or hypertriglyceridemia, then this should be controlled by the drugs. In the next step, you will go for the control of abdominal pain, because abdominal pain is common in the chronic pancreatitis, though it is not specific, and this is multifactorial. So in order to control this pain, you can use tramadol like drugs, that is drugs which are narcotic drugs you can use to control this pain, but sometimes it cannot be controlled even by the narcotic drugs, and it may cause the narcotic bowel syndrome, that is pain because of these drugs similar to that of irritable bowel syndrome. So the pain of chronic pancreatitis is multifactorial. It is because of stretching of the bile duct of the pancreatic duct. It is because of stretching of the pancreatic capsule. It is because of inflammation of the pancreas. So this is the multifactorial. In the patients of chronic pancreatitis, it is seen that in the cortical region of brain, sometimes the receptors are increased in number. So this is multifactorial. So in order to control this pain is very difficult. So you can use to control this drug, tramadol like drugs can be used, analgesic drugs can be used, but they are less effective. So the particular cause will have to be eliminated in order to control the pain. Cause, that means if there is lithiasis of pancreatic duct, it's to be removed from there. If there is a stricture, you will have to cure the stricture. If there is inflammation of the pancreatic parenchyma, then you will have to control that inflammation. Then only you can control this pain, because it is multifactorial. It is though not specific, but if it is present, patient is very uncomfortable. In the next step of treatment is treatment of diabetes. In the treatment of diabetes, you will have to give insulin. You will have to adjust dose of insulin in order to control the diabetes. This diabetes cannot be controlled with the help of oral hypoglycemic drugs. So this type of secondary diabetes can be controlled only with the help of insulin. So insulin is must in the cases of chronic pancreatitis whenever there is hyperglycemia, and if patient doesn't takes this insulin, then definitely he will go in diabetic ketoacidosis. So in these cases, again you will have to manage diabetic ketoacidosis if patient is not listening to the suggestion properly. If he is not understanding the suggestion, then in those cases repeated admission with diabetic ketoacidosis can occur. Now these patients of chronic pancreatitis, as they are having malabsorption symptoms, in these cases you will have to give pancreatic enzymes in large doses. With the help of pancreatic enzymes, you can control the malabsorption syndrome and patient can be benefited. If patient is having hypocalcemia, then in these cases you will have to give calcium as in the supplement form, because if you will not give the calcium, then in these cases the chances of pathological fractures are more in the later stages. If you are suspecting autoimmune type of chronic pancreatitis, then you can you will have to go on the lines of management of chronic pancreatitis because of, if it is because of autoimmune disorders. So you will have to manage in the same way as you manage autoimmune disorder with the help of steroids. So in some studies, steroids have been used in the management of chronic pancreatitis if it is because of autoimmune origin. But though the in the treatment with the help of steroids, it was not so successful, but still you can use steroids in low doses in the cases of chronic pancreatitis if it is suspected to be of autoimmune origin. So this is all about chronic pancreatitis. Thank you.